Excellent. All right. Well, welcome everyone. Thank you for joining us today. This is our first McGill MPU Noon Seminar of 2024. Welcome back. I'm Pete Watson. I'll be hosting our seminar today. We have the pleasure of welcoming Dr. Sarah Aubert. Sarah is a first-year medical physics resident at the Princess Margaret Cancer Centre in Toronto. She completed her PhD last year at the Toronto Metropolitan University, where she worked on investigating the feasibility of photon-counting angiography, and she's here today to talk to us all about that. So thank you very much, Sarah. Please take it away.
Awesome. Thank you so much for the introduction. All right, so a little bit more about me before I jump into today's talk. So as mentioned, I recently completed my PhD at Toronto Metropolitan University, formerly known as Ryerson University, and I did my bachelor's degree in medical physics at McMaster University. And so the objectives for my talk today are going to be outlining some of the current applications and limitations of subtraction-based and dual energy imaging techniques that we can use to improve visualization of contrast-enhanced vasculature, such as the coronary arteries. I'm going to be talking about some recent technological advancements that have led to the development of photon-counting X-ray detectors. And then I'm going to talk about some of the work I did in my PhD, where we looked at the feasibility of using a photon-counting X-ray detector for improved imaging of coronary heart disease. So I just want to put up my acknowledgements and funding sources. So as mentioned, the work I'm presenting today was part of my PhD work and was funded by these three sources here. Cardiovascular disease is the second leading cause of death in Canada and the leading cause of death globally, with an estimated 17.9 million deaths being reported in 2016. Cardiovascular disease, or CVD, is an umbrella term that encompasses a variety of disorders that affect the heart or blood vessels and refers specifically to a buildup of plaque in the arteries. Examples of CVD include peripheral artery disease, cerebrovascular disease, and coronary heart disease, which is the most common type of CVD. Accurate diagnosis and treatment of coronary heart disease requires adequate imaging with an iodinated contrast agent. And so patients who are suspected of having coronary heart disease will receive something called a coronary angiogram. This is a cardiac catheterization procedure that is used for both diagnosis and intervention. And it works by inserting a catheter in through the vein in either the groin or the arm and threading it up through to the arteries. The patient will then be positioned between our X-ray source and our X-ray detector, and an iodine contrast agent will be administered. Then they will require a series of X-ray images. So here we can see an example of what an angiogram of the left coronary arteries would look like. We use iodine as a contrast agent here because it attenuates X-rays differently than the surrounding materials due to its K edge at 33 keV. So there is potential to improve the visualization of heart disease by subtracting surrounding anatomic noise, such as bone and soft tissue that is around our contrast-enhanced vasculature in our angiographic images. Currently, there are two subtraction-based methods that we can use to remove anatomic noise like bone and soft tissue. The first is a technique known as digital subtraction angiography, or DSA. And the second is called dual energy angiography, and it's implemented with a fast KV switching technique. Digital subtraction angiography, or DSA, is the reference standard for imaging near stationary vasculature, such as our peripheral arteries. And it works by acquiring an image before the patient is injected with iodine and after the patient is injected with iodine, and subtracts them to produce this iodine-specific image of the vasculature that we can see in the photo here. However, DSA cannot be used to visualize the coronary arteries because of the time delay between the pre and the post-injection images. This leads to motion artifacts that ruin the quality of our image, like we see here, and therefore DSA cannot be used to help us improve visualization of the coronary arteries. However, if we compare the quality of images taken using subtraction-based techniques of DSA, shown here on the left, and an angiogram shown here on the right, we can see that DSA has much greater contrast than our angiogram. So this raises the question, why don't we have a better method of imaging the coronary arteries? Another type of subtraction-based imaging that overcomes the limitation imposed by cardiac motion, precluding the use of DSA, is a technique known as dual energy angiography implemented with fast KV switching. This technique works by acquiring a low energy X-ray image, followed by a high energy X-ray image. We can then apply a weighting factor to our low and our high energy images and sum them together to form either a soft tissue or bone suppressed dual energy image. This technique overcomes limitation imposed by motion that precludes the use of DSA, since our low and our high energy images are acquired in rapid succession. However, this technique imposes a high demand on our X-ray tube since it requires heavy filtration of the high energy spectrum. This limits the amount of photons that we have available to produce our dual energy images in the short exposure times that are required to reduce motion artifacts, and this in turn results in a low signal to noise ratio in our images. Recent advancements in technology have led to the development of something called a photon-counting X-ray detector. These detectors can estimate the energy distribution of photons at rates that are adequate for X-ray imaging applications. Unlike conventional energy integrating detectors, photon-counting X-ray detectors can give us information about the energy of each transmitted photon, and therefore provide information about the material that the photons have been transmitted through. And so how do these detectors work? Photon-counting detectors work by counting the number of photons within predetermined energy windows. They are made up of semiconductor sensors that are connected to these pixelated anodes, which are in turn connected to ASICs in parallel channels. Each channel is composed of an amplifier, a pulse shaper, a pulse height comparator, and has N counters per pixel. In our detectors, we have an electric field that is generated along the depth direction of the sensor. And so, when our X-ray photon arrives at the photon counting detector, it will deposit energy and generate an electric charge. This charge will start to travel towards the electrode under the influence of the electric field, where it will induce a pulse signal that is going to be processed by the electronics. The height of this pulse will be compared to a given threshold value, and if it exceeds the threshold, a count will be registered in the associated comparator. So in this example of how our photon counting detector will work, we have a 100 kVp spectrum incident on our phantom, and it's going to be transmitted through the phantom and incident on the detector in some energy in keV. In this example, our detector's predetermined energy threshold is 50 keV. And so if our transmitted photon has an energy greater than 50 keV, a count will be registered in bin number 2. However, if our transmitted photon has an energy of less than 50 keV, a count will be registered in bin number 1. In this work, we're proposing the use of a single exposure dual energy imaging technique implemented with a photon counting X-ray detector, as the use of a single exposure photon counting approach would not require heavy filtration of the X-ray spectra that limits the use of dual energy angiography with fast KV switching, and it would overcome motion limitations that preclude the use of DSA since we're using a single exposure. However, it would still allow for us to remove anatomic noise, like bone and soft tissue, which would potentially allow us to improve the visualization of cardiovascular disease. This proposed single exposure photon counting technique would use a single exposure incident on our patient and use a predetermined energy threshold to distinguish between our low and our high energies. And so in this example, our low energy bin image would be any photons with an energy less than 50 keV, and our high energy image would be made of anything with photons greater than energy of 50 keV. We could then use our low and our high energy image acquired in a single acquisition, weight them, and produce a soft tissue suppressed dual energy image. Previous work has found that photon-counting angiography has the potential to provide images of similar quality to that gold standard of DSA in terms of the iodine signal-to-noise ratio. However, these studies assumed ideal detector responses, but this does not account for the physical phenomena that we observe in photon-counting X-ray detectors. Photon-counting detectors face limitations imposed by physical phenomena like pulse pileup, charge sharing, and K-escape X-rays, all of which can degrade our image quality. And so pulse pileup occurs when our photons generate multiple pulses that overlap, causing them to be observed as a single pulse. This can result in a loss of counts or a misregistration of our photon energy in our photon counting detector. And this distortion can cause inaccuracies when we're trying to do material decomposition. Charge sharing occurs when the charge cloud that's generated interacts near a pixel boundary, like we can see here. And so when our photons interact, they generate a charge cloud, which will grow as it moves towards the anode due to diffusion and the Coulomb force. And if it's detected near a pixel boundary, we can have decreased energy detected in the initial pixel and a lower energy detected in adjacent pixels. And this will degrade the spatial resolution of our produced image. And finally, we have K-escape X-rays. So our photons that interact via the photoelectric effect will release a characteristic X-ray that can be absorbed in the initial pixel, an adjacent pixel, or it can escape the detector altogether. This will result in decreased energy recorded in our initial pixel, as well as this low energy tailing that we see in the example here. So to address some of the effects of charge sharing and K-escape X-rays in photon counting detectors, some detectors may incorporate an anti-charge sharing scheme to compensate for these effects, known as analog charge summing technology, or ACS. And these schemes work to compensate for these effects by detecting coincident photons in adjacent pixels and reconstructing the charges to reallocate the total charge to the incident pixel. So in this example, our initial pixel interaction is in the center, but we're detecting lower energies in surrounding pixels. The ACS would sum a 3x3 region of interest of the surrounding pixels and reassign all of this energy to the initial pixel interaction site. And so the goal of this work specifically was to look at the feasibility of using this proposed single exposure dual energy approach implemented with a photon counting X-ray detector as a potential alternative to current dual energy imaging approaches for improved imaging of the coronary arteries. There were three objectives for this work. The first was to look at developing a theoretical model that incorporates realistic X-ray detector response to account for those physical phenomena that we see in photon counting detectors that we just talked about. And we did this to evaluate the image quality of both the gold standard DSA and energy resolved approaches. The second objective was to experimentally optimize our proposed single exposure approach that we implemented with a 2-bin photon counting X-ray detector that we had in our lab. And finally, we set out to compare the quantum noise properties of our proposed single exposure approach with the two existing subtraction approaches, KV switching and digital subtraction angiography. And again, this was done with the 2-bin photon counting X-ray detector that we have in our lab. And so in our first objective, we were looking at developing theoretical models to look at the realistic response of our photon counting X-ray detectors. For the study, we used the zero frequency signal difference to noise ratio per root entrance error kerma as our figure of merit, where here S and B represent the average pixel values in the signal and background region of our images. WS and WB represent the zero frequency noise in the signal and background regions. And kappa represents the incident error kerma. We modeled both ideal and realistic X-ray detector responses in a MATLAB simulation for the following three scenarios. DSA, an energy resolved approach with 3 energy bins and a 2-material decomposition, which should allow us to suppress one type of material, such as bone or soft tissue, and an energy resolved approach with 3 energy bins and 3 materials, where this last one here, the 3-bin, 3-material approach, would allow us to use the photon counting detector to generate an iodine-specific image by removing both bone and soft tissue, like we see in DSA. So we did this for both ideal and realistic detector responses. And we also incorporated that anti-coincidence ACS, which I'm going to go into a little bit more detail in the next few slides. And so for our models, we used a numeric model to calculate the average image signal and the image noise. For our digital subtraction angiography approach, we incorporated a realistic detector response for a cesium iodide energy integrating detector that has been previously described by Haddock and Yoon and validated by members of our lab. This model accounts for physical phenomena that we see in photoelectric interactions, optical blur, optical collection efficiency, and noise aliasing. For our energy resolved approach with our photon counting detector, we use a Monte Carlo validated model for a cadmium zinc telluride detector. This model accounts for spectral degradation and spatial energetic crosstalk that are produced by charge sharing and characteristic emission. And as mentioned, we also modeled this using the ACS to compensate for some of the effects of charge sharing and emission. So our model was modified to account for energy that it was deposited in pixels surrounding the initial interaction X-ray site. And it sums the energy deposited over a 3x3 region of interest within our detector and assigns the corresponding energy back to the initial interaction site. So here are the results of our theoretical comparison of our large area SDNR for our DSA, our 3-bin 2-material energy resolved approach, and our 3-bin 3-material energy resolved approach. So here we're looking at the optimized figure of merit for each of these approaches, where the first bar here represents an ideal X-ray detector response, the middle bar represents a realistic detector response, and the last bar is our realistic response with our ACS incorporated. So we're correcting for some of the charge sharing and characteristic emissions. And what we can see in this plot is that our 3-bin, 3-material energy resolved approach does not produce, with a realistic response, does not produce images of similar quality to that of the gold standard DSA. And that our 2-material decompositions shown here produce a better result than our 3-material. So this suggests to us that our photon counting approach is likely not able to produce images of similar quality if we're trying to produce an iodine-specific image. On the other side of this, we can see some simulated images that show us the same thing. And so in our first one, we see our digital subtraction angiography approach, where we have 3 different vessels of iodine. In the middle, we see when we only remove soft tissue, so a 2-material decomposition, and our 3 iodine vessels. And on the far side, we see our iodine-specific image where it is very difficult to see the vessels. And so what we concluded from this study was that energy-resolved angiography, when using an iodine contrast agent, is not going to enable iodine-specific DSA-like imaging of the coronary arteries at clinical relevant patient air kermas. We can see here that the quality of this image does not compare to our DSA image. We also concluded that our energy-resolved approach may enable suppressing soft tissue while maintaining image quality that was 50 to 75% of that of DSA, in that our middle image here was more comparable to our gold standard. And so this led us into our second objective, in which we set out to experimentally optimize the quantum noise properties of our proposed single exposure approach using a 2-bin photon counting X-ray detector. And so to do this, we developed an imaging phantom to produce dual energy images with the benchtop detector in our lab. Our phantom consists of either a 20 or 30 centimeter thick water tank with PMMA walls, and this PMMA step wedge that is filled with iodine ranging in area density from 16 to 48 milligrams per centimeter squared. It also uses these 3 varying amounts of PMMA, so 2, 4, and 6 centimeters, to represent soft tissue. On the front surface of the phantom, we have this region of aluminum that we use to simulate bone in our images. Then, to demonstrate the ability to better visualize vessels, we imaged this second phantom with vessels ranging in diameter from 2 to 5 millimeters that are filled with an iodine solution that is 100 milligrams per milliliter. This phantom is 21.5 centimeters thick in the X-ray direction and includes this 4 centimeter thick clutter phantom that is used to demonstrate the ability of this technique to suppress soft tissue variations. And so in the background of this photograph, we can see that it is composed of different sized PMMA spheres. The photon counting X-ray detector that we used in this experiment was a cadmium telluride semiconductor, the X counter, and it has 100 micrometer pixels, a 0.75 millimeter thickness, and 2 dynamic energy bins. It also has the analog charge summing capabilities, and it's housed in this custom X-ray cabinet shown here. And so for this study, we imaged our phantom using tube voltages ranging from 90 to 150 kV. This range is higher than is what is seen in typical angiographic applications, but was selected based on previous research that showed that higher tube voltages are likely required for photon counting angiography applications. The energy threshold that we used to separate our low and our high energy image varied from 33 keV to 75% of the maximum energy. We repeated this study for both phantom thicknesses, the 20 and 30 centimeter. And we also determined an appropriate air gap and field of view to range SPR for two different scatter settings. And so for our first high scatter condition, we picked an SPR that was between 0.8 and 1. And for our low scatter condition experiments, we picked an SPR that was between 0 and 0.2. So this corresponded to using a field of view of 12 by 12 centimeters and air gaps of 15 and 80 centimeters. For all of our experiments, our incident air kerma ranged from 0.68 to 1.58 milligray, and we acquired 10 of the same data sets for each combination of tube voltages and energy thresholds. For each tube voltage and energy threshold combination, a dual energy image was generated using the gain-corrected low and high energy images, as well as this optimized soft tissue suppression parameter that allowed us to remove soft tissue from our dual energy image. For each of the dual energy images that was then generated, we determined the signal difference to noise ratio per root air kerma, shown by the equation here, where here DE iodine and DE background represent the average pixel value in the iodine and background regions. We can see those regions in the image on the bottom here, where the ROIs show this is our region of iodine, and this is our region of background, which just contains water. The sigma terms here represent the pixel variance in these respective regions, and kappa represents the air kerma that is incident on our phantom. And so we did this for each well of iodine and averaged over 10 different data sets for each tube voltage and energy threshold combination. For each of our phantom thicknesses and scatter conditions, we repeated this experiment. And so what we did is we took the SDNR per root kerma, shown here, and we plotted it as a function of energy threshold, where each different shape here represents a different tube voltage. So the data shown here is for our 30 centimeter thick phantom under high scatter conditions. And so we used a quadratic fit to calculate what energy threshold would maximize this SDNR per root kerma for each tube voltage, and then repeated this analysis for each phantom thickness and scatter condition. So we then took this optimal threshold E2 and plotted it as a function of tube voltage. We did this again for each of the different scatter conditions, where shown here, this is for a 30 centimeter thick phantom. To generalize this result a little bit further, we determined what percentage of photons was present in our low energy image that corresponded to this optimal threshold. And we plotted that as a function of tube voltage, where here we can see that for both low and high scatter conditions, our optimal threshold corresponded to about 3/4 of all photons, both primary and scatter, being present in the low energy bin. We then took our energy threshold optimized signal difference to noise ratios, shown here, and plotted them as a function of tube voltage to determine the optimal tube voltage. And it was found that SDNR increased approximately monotonically with tube voltage up to 150 kV for both low and high scatter conditions for both phantom thicknesses. So in this study, we've demonstrated that it is feasible to use a single exposure photon counting approach to suppress soft tissue. And here we have an example of what that would look like. So these images were acquired using optimal parameters, so a tube voltage of 150 and an energy threshold separating the low and high energy image of 81. So here in our low energy image, we have all photons below 81 keV, and in our high energy image, we have all photons between 81 and 150. We can see that we have our 3 regions of varying iodine, our 3 amounts of PMMA, so 2, 4, and 6 centimeters thick, as well as our region of aluminum to represent bone in the bottom corner. So here we've acquired our low and our high energy image. We've applied some optimized weighting to remove the soft tissue. And in our soft tissue suppressed dual energy image, we can no longer see the variations in the amount of PMMA or soft tissue along the top. So in our second example here, to better demonstrate how we can use this technique to better visualize the vessels, we imaged our second phantom where again, we're going from 2 to 5 millimeters in diameter as we move up the images here. And these iodine vessels are filled with an iodine stock solution that was 100 milligrams per milliliter. The image set on the top shows you non-ideal parameters, so a tube voltage of 90 kV with a threshold separating the low and high of 49. And the bottom set of images are images acquired under the optimized parameters. So again, a tube voltage of 150 and a separation of 81. And we can see that for both our non-optimal and optimal parameters, we are capable of suppressing those soft tissue variations that we see in our low and high energy images and our dual energy images. And so what we concluded from this study was that our image quality was increasing monotonically with tube voltage up to 150 kV, and that our optimal energy thresholds always corresponded to approximately 2/3 of the primary photons, or 3/4 of all photons, being detected in the low energy bin. And this result was independent of both tube voltage and phantom thickness. This is an important finding because it means we don't always need to exactly match the scatter and thickness conditions from our calibration. So this led us into our third objective, to compare the noise properties of this optimized proposed single exposure approach that I just presented with our other two subtraction techniques, KV switching and DSA. And so as a reminder, in our second objective, we went and optimized our single exposure dual energy approach. And we did so by optimizing our tube voltage, our energy threshold that separates our low and high energy image, as well as our soft tissue suppression parameter. In this study, we set out to optimize a digital subtraction angiography approach, and we did so by optimizing the tube voltage. We also optimized a KV switching dual energy approach, where we looked at optimizing both the low and high energy tube voltages, as well as the dose allocation factor, which tells us how much of our total dose comes from our low or our high energy image, and our soft tissue suppression parameter. And again, we did each of these optimizations for 2 different phantom thicknesses under 2 different scatter conditions, so we could quantify the effect of patient thickness and the amount of scatter on image quality. This figure shows the SDNR per root kerma, so our figure of merit, for each thickness and scatter condition that we investigated for each of the 3 techniques. So we have our 30 centimeter phantom, our 20 centimeter phantom under high scatter and low scatter conditions, where here the first bar represents the DSA or the gold standard technique. The middle bar is our KV switching technique, and the last bar represents our proposed single exposure approach. In this plot, we can see that our KV switching technique is capable of producing images that are greater than or equal to 100% of the quality of that of DSA. And our single exposure approach is capable of producing an SDNR that is 75 to 85% of that of DSA. However, as I mentioned at the start of this talk, KV switching often requires much higher heat units to produce the same amount of quality, which can lead to tube loading problems. And so we also set out to look at what the heat units were required to match the SDNR that we see in our KV switching approach. So here we're looking at the heat units required per SDNR squared, again for each different thickness and scatter condition for each of the 3 techniques. And what we found is that while KV switching is capable of producing better image quality than single exposure, it requires approximately 2 times more heat units than our single exposure approach to achieve the same quality of image. And it requires almost 4 times more heat units than our single exposure approach to achieve the same air kerma. Therefore, our proposed single exposure approach is capable of producing images that are 75 to 85% of the quality of that of DSA, while requiring significantly less heat units than conventional KV switching approaches. So in addition to this study, we also looked at applying something called the anti-correlated noise reduction, or ACNR, to our vessel phantom images. And we calculated the resulting iodine SDNR. So ACNR exploits the quantum noise correlations between an iodine and a tissue image produced by dual energy subtraction of the same set of low and high energy images. So in this case, we take an iodine-only image from our tissue-only image after our tissue image is filtered with a high-pass filter. And so it follows what we were looking at before with the addition of this high pass filter and subtracting out a tissue-only image. And so here we have the images of our vessel phantom with that anatomic clutter that we acquired using optimal technique parameters that were found for each of the three techniques. So here, the top row represents photon counting, single exposure dual energy imaging. The middle row represents KV switching dual energy imaging. And the bottom row represents digital subtraction angiography that we're using as our gold standard. So our first set of images here represent our low and our high energy image of our phantom. So in this example, these were acquired using a tube voltage of 150 kV, and the energy separating these is 81. So anything below 81 is here, above 81 is here. Similarly, we have our low energy KV switching image and our high energy KV switching image. We then use our weighted tissue suppression to come up with a tissue-only and an iodine-only image. And so in our tissue-only image, we're suppressing bone, which we see here in the image, as well as iodine to come up with just these soft tissue variations. Similarly, in our iodine-only image, we're suppressing soft tissue and bone. Then if we go back and we apply our dual energy with ACNR equation shown here, we can produce this iodine image with our ACNR correction. We can see that this improves the visualization of our vessel structures for both our single exposure approach as well as our KV switching approach. And when compared to our gold standard DSA, we can see that the images visually have similar quality. And so here we looked at quantifying what these images looked like. So we have the SDNR per root kerma on the y-axis as a function of tube diameter, where again, our tubes range from 2 to 5 millimeters in diameter. The dataset on the bottom here represents our DSA, KV switching, and single exposure approaches without this ACNR correction. We can see that when we incorporate ACNR, we get this KV switching line up here and the single exposure line up here. And we can see that incorporating it results in increasing the SDNR by a factor of 2 or greater for both techniques. And so what we concluded from this study was that for our matched patient air kermas, without this ACNR correction, the proposed single exposure dual energy imaging technique was capable of producing images of quality that were 75 to 85% of that of DSA and KV switching. In the meantime, this single exposure approach required approximately half of the heat units to match SDNR and a quarter of the heat units for matched patient air kermas to that of KV switching. In addition, if we incorporate our ACNR correction, single exposure dual energy angiography and KV switching dual energy angiography can both provide iodine signal difference to noise ratio that is greater than DSA by a factor of 2 or more, making this an area that we want to further look into. There are, however, some limitations with this study, specifically comparing the quantum noise properties of these 3 techniques, and that all 3 techniques in our study were implemented with a photon counting detector. In reality, digital subtraction angiography and KV switching would likely be implemented with an energy integrating detector. However, when comparing imaging systems with different spatial resolutions and noise textures, we require a model observer that accounts for the frequency-dependent signal and noise properties of each technique. And as such, this study should be interpreted as a first-order comparison that gives us insight into how the quantum noise properties of these 3 techniques compare, while we control for spatial resolution and noise texture. The future work of this research is to look at implementing this ACNR back into that triple energy bin photon counting angiography. So in our theoretical study, we determined that we would not be able to produce an iodine-specific image using a photon counting X-ray detector that is similar in quality to that of DSA. However, in our 2-bin images, we have shown that if we incorporate ACNR, we can improve image quality by up to a factor of 2. So we wanted to implement this ACNR in a 3-bin photon counting approach to see if we are able to produce iodine-specific images, such as that of DSA, of comparable quality. And so here we have an example of that. We have 3 different energy bin images. So the first bin is from 18 to 32 keV. The second is from 32 to 53. And the third is anything greater than 53. And these were acquired using a tube voltage of 80 kV. So we can see we have our vessels in the image here, as well as a small region of aluminum to simulate bone down at the bottom. And we have the soft tissue variations induced by that clutter phantom along the back. So in doing this, we've produced our iodine specific image, or our iodine only image shown here, our soft tissue only image, and our bone only image. And then we can apply our ACNR correction to generate a dual energy image, and we come up with this image shown in the bottom here. And so to quantify this, we looked again at the SDNR for each of these vessel diameters. In this case, we're just looking at vessels of 3, 4, and 5 millimeters, with and without the ACNR. And so we can see that again, without ACNR, our values are rather low. When we incorporate this ACNR correction, we improve image quality in terms of signal difference to noise ratio drastically. And so overall in this study, we have found that this single exposure dual energy angiography approach with a photon counting X-ray detector may allow us to overcome limitations that have previously prevented dual energy imaging of the coronary arteries. And with that, I would like to thank you for your time, and I'd be happy to take any questions.
All right, thank you very much. Excellent talk. We have time for questions, so please feel free to unmute and ask your question out loud, or if you type the question into the chat, I'll read it out loud for you. I have a bunch of questions I wrote down. And they're probably the same questions I asked you when you gave this talk to the comp imaging seminar, but that's okay. I'll remember it the second time. But if anyone wants to go first. I always feel like it's kind of the host's duty to ask a question, but then the host can monopolize the question time too, so I don't want to do that. All right, I don't see anyone raising hands. My first question, this was super interesting. You made a point that everything you studied so far was with your kind of experimental photon counting setup, and that in practice, the clinically available angiography systems are going to be using, well, they all use energy integrating detectors. Based on your research, what are the, like, what do you have to be able to make the case that photon counting detectors for a vendor to want to make a system that has this and use your single exposure dual energy? What do you have to beat? Like, what are the current clinically available SDNRs for DSA and KV switching using a energy integrating detector? Do you have a sense of that?
Yeah, so I don't actually have, I probably used to at one point, so I don't have the hard values of what the SDNRs are. But I think the line of logic is that the next step would be to compare the frequency content of the detector. And
Right.
so currently they use these energy integrating detectors, and they're well-known detectors and the properties are well studied. And so the noise power and the MTF and DQE are well understood. They're not currently well understood for these photon counting detectors in terms of their impact on image quality. And so I think in order to compare them, that study has to be done first.
Okay. Yeah, I think that was a question I had last time, is that I would assume implicitly that just because you have a smaller pixel size and the fact that you don't have scintillators and optical blur, you should be getting a higher spatial resolution with your panel, right?
Yep.
So that's already giving you a boost in the MTF. So nice. Okay. The motivation for this was really saying that, you know, DSA is great, but it takes too long, so you can't image coronary or anything that's going to be moving like a heart. How, in terms of temporal speed, how fast is it to do the single exposure DE? Is it just as fast as the KV switching, so you can get many frames per second?
Yeah, so it's actually faster than the KV switching. So there's a group right now out of Buffalo that is looking at the temporal speed of this. And I believe they're using something like 1,000 frames per second. And they do this for like our, what's it called? Aneurysm studies. And they study really high speed frame acquisitions using a photon counting detector. And so their application of the photon counting detector is actually not like ours in suppressing material, but they're taking advantage of that quick acquisition time and that temporal.
So it's not a problem. It's actually setting the bar in terms of how fast you can be
Yes.
firing data. Okay, very nice. Awesome. The ACNR correction. So from how you described it, it's really just you're basically just using the correlations between the high frequency content of the images with higher and lower energies.
Yep.
And removing that. So you're basically trying to get rid of all, you're basically saying all high frequency data is noise, get rid of it. And from the images you show, it looks like it really does enhance the SDNR because essentially you're removing noise. So
exactly, yeah.
Signal stays the same, noise decreases, SDNR goes up.
Yep.
I'm curious though, does that affect your detectability of edges and small features though? Because you're essentially removing that content. And from the images you showed, it's very obvious what is a vessel and what isn't. But what if you had something that was more detailed?
Yeah, so I think they're actually looking at this right now in the lab where this work was done, at that type of application for mammography. And so in that case, you do have a lot smaller vessels and more overlap of different types of tissues. And so I don't think the results are done yet, but I do think that that is something they're looking into of how this does impact the edges when you're looking at really small structures.
That's something I would think would be an issue unless you're able to intelligently tease out what is high frequency noise only, and then what is a high frequency like an edge. Because I'm not sure when you were doing the correction if you ever displayed what those images look like, but I imagine that they kind of look like they're uniform wherever there's nothing happening, and then as soon as you hit the edge of your tube, you see a line, you see like the lines.
Yeah.
You could maybe use that information that, okay, whenever I have a boundary of a structure between background and object, keep that. And then if I just have high frequency that's more, uniform or amorphous, that's noise.
Mm-hmm. And the way that we're subtracting them, it's the same single image set that they're being subtracted from. And so what ends up happening is it's subtracting the correlated noise, but where those lines come in, it's consistent among each of the data sets. And so it knows that that's an edge rather than.
Right, that's true. That's a good point. Okay, cool, thank you. Very good. At one point you talked about studying low scatter, high scatter conditions, and I just had a question about the experimental setup. So to get low scatter, you basically just boosted the air gap between your scattering object and the detector. But then how did you keep the field of view the same, right? Because you're geometrically magnifying.
Yeah, so it magnifies in the image, so the field of view was fixed at the SSD. So it was a fixed 12 by 12 hitting on the surface of the detector. Yeah.
On the detector, okay.
Yeah.
Yeah, okay, that makes sense.
But in our larger field gap images, we actually only have one vessel because of the magnification, you're not able to see all three.
Right. Okay, that makes more sense. And I guess clinically, it's always a high scatter condition because you're always putting the panel as close as you can to the patient. So I understand you did this for the study purposes.
Yeah.
But in practice, it's always going to be used in a very high scatter environment. So it's good to know how it performs. I feel like, again, I'm doing that thing where the speaker monopolizes the questions. Does anyone in Zoom land have a question? No, I wrote down a few more. Again, it helps that I saw this talk twice because I have new questions. I have probably the same questions and some new ones. So it's a very nice work. I have to give you kudos for that. So your figure of merit's the SDNR as a function of entrance dose, which is, a good figure of merit. Obviously, if you boost the dose, you're going to get bigger, better SDNR because the noise is going to go down. But then one thing I was thinking is you show the trend with KV and the SDNR keeps on going up, which is indicating that, if we want to have better image quality and detectability, we should just be boosting the KV. But then I would think if you made the same plot, but instead of just entrance dose, you looked at the effective dose to the patient, that would actually reach a maxima and start to decrease. Is that?
Yeah, that's our hypothesis as well. So most clinical angiographic systems actually only go to 120 kV. So we went up to 150 just because it was what our system was capable of. But we do expect that as you keep going, it will kind of plateau.
Yeah. Yeah, that's one thing we never really talk about, but yeah, the exit dose is going to start to get significant, right, as the higher, as the KV goes up. So yeah, that's just something I wrote down. Cool. And then again, going back to the first question about comparing to what's clinically available now, how everything's energy integrating, are you aware of any vendors who are considering or looking into developing a photon counting flat panel for fluoroscopy?
Yeah, I don't know about flat panel. I do think we're going to see it relatively soon, just with the implementation of the photon counting CTs that we're seeing.
Yeah.
So I think that eventually it's coming. There
Okay.
will be some kind of thing that exists, but so far I think the excitement is around the photon counting CT, which is great. And I think once that picks up a little bit more speed, you could see like a flat panel fluoroscopy
Right.
implementation.
Because I mean, you have one, right? You have one in your lab. It's just a bit.
Yep.
It
It's
looks like,
it's very small. Yeah.
yeah, but the proof of concept is there. It just has to be developed into a, I mean, radiography sized.
Yeah.
Nice. All right, that's all. Those are all of my questions. Thank you. Very, very well answered. All right, anyone else? Last chance for questions. Doesn't have to be as detailed as mine were. Don't feel like your question will be naive. Doesn't look like it. All right, well, with that, I'd like to thank Sarah again for speaking to us. And thank you all for attending here today. And we'll see you all later on. So thank you so much.
Thank you.
Okay, bye-bye.